Good afternoon, one and all. Welcome to the fourth session of the third SDG series in NHSRC in collaboration with DSPRUD. I would like to welcome Dr. Jen Srivastava, sir, Advisor Quality and Patient Safety Division, Dr. Atul Kotwal, sir, Sena Medal, Vishisht Seva Medal, Executive Director, NHSRC. I would also like to welcome Dr. Sangeeta Sharma, President, DSPRUD. And we also have our guest faculties for this session, Dr. Sumit Pachori, who is the consultant in the Department of General Medicine in the Maulana Azad Medical College. And we'll also be having one more faculty, Dr. Nair Jamshed, who is the additional professor in the Department of Emergency Medicine in the All India Institute of Medical Sciences, AIIMS, New Delhi. Sir, I would like to welcome you to please deliver the welcome address. Dr. Jain Srivastava, sir, over to you, sir.
Thank you, Aman. And at the outset, a very warm welcome to our ED, Major General Professor Atul Kotwal, sir. Under his guidance, this initiative was taken about 2.5 years back when NHSRC, in collaboration with Delhi Society for Promotion of Rational Use of Drug, led by Professor Sangeeta Sharma, decided that let's do something for improving the clinical skills and extending the support for the knowledge and skill enhancement for all the functionaries, more so for the primary healthcare facilities, those who are working in the PHCs, in the community health center, CHOs are there. And also in the PHCs, normally the doctors are all alone. The series had been also well appreciated even at the functionaries where like community health center, district hospital, many specialty hospitals, medical colleges, and where there are not many opportunities available for skill enhancement. The people, they get busy in day-to-day activities, attending the OPDs, going back. And based on the learning and the responses which NHSRC and Delhi Society for Promotion of Rational Use of Drug received, that in the third series we have modified a bit, that now that clinical sessions are divided into two parts. One is primarily targeting the primary healthcare facilities, and the second part is for the secondary healthcare facilities. And of course, the third, the sheet anchor, Professor Sangeeta Sharma, in fact, she has been regularly conducting all the sessions. Like initially we had, this is in fact the 28th session in succession. And the attendance has not gone down, thinned. I mean, as of now also there are 200 odd for participants who have joined, and many more will be joining. So somewhere this is contributing. Based on the learnings of this STG series, in fact, we have taken the approval of our Executive Director, Major General Professor Atul Kotwal, sir, to launch a separate series on every second and fourth Saturday for the supporting the primary healthcare facilities implementation of the national quality assurance standards in the country. Because fact remains that we have not been able to connect individually with all the CHOs, all the Ayushman Arog Mandir, which were earlier known as the health and wellness centers, and the primary healthcare centers and urban, including urban. The number itself is about 150,000 plus. So that series will be starting. And before, in fact, I request General Kotwal sir to deliver his inaugural address. I would request all the participants that please don't hesitate in asking the questions, and whatever is relevant for you in your given setup. So please don't hesitate that somebody may say that I don't know this much or I don't know that much. Our faculties are very, in fact, supportive, and I will be failing in my duty if I don't acknowledge gratefully the support and the involvement of the current two faculty members who are there today. Besides, of course, Dr. Sangeeta Sharma has always been there. Like Dr. Sumit Pachori is already logged in, and Dr. Nayyar would be joining. A very warm welcome to both of you, and we look forward to your deliberations, your discourse in taking forward. I request General Kotwal sir to deliver the inaugural address.
Thank you, sir. Good afternoon, Dr. Jain Shrivastava, sir, Dr. Sangeeta Sharma, Dr. Pachori, and also Dr. Jamshed will join us later. I must compliment the quality and patient safety team led by Dr. Shrivastava, sir, and also Dr. Sangeeta Sharma. And I think you're a one woman army. So that's for entire DSPRUD for working with NHSRC for this excellent initiative. And before I just share few of my thoughts, I would also like to commend and compliment and thank a large group of specialists, doctors, staff nurses, CHOs, and other professionals from different disciplines who have been regularly joining these online sessions on the SDGs. So this is the third in the SDG series, and this is the fourth session in that SDG series. And I'm told there are 18,000 healthcare professionals who have attended till now, and then 3,000 have attended the pre and post sessions also, and certificates have been distributed for that. And this SDG series actually addresses a very important issue as such, the gap between the clinical practice and also the knowledge of standard treatment guidelines, which is very evident and impacts the quality of care. It not only impacts the quality of care, it also leads to a lot of comments by the non-medicos. We deal with the health administrators at the national level, at the state level, the health secretaries, the additional secretaries health at the state level, other officials. The standard discussions and all many times veer towards that कि क्या दवाई लिखते हैं, है ना, क्या दवाई देते हैं. So that comes from a lot of us either unaware of standard treatment guidelines or not following the standard treatment guidelines. And even the patients, nowadays we know patients already Google the symptoms and also the treatment also when they come to you. So it's time that we also increase our knowledge and we also follow the standard treatment guidelines, standard treatment workflows, so that people have more and more faith in us. And that faith will come once they know that yes, evidence-based medicine is being followed, and also quality and patient safety is there in the minds of all the healthcare workers. And that will be there only when we follow certain kind of guidelines, which can defend also subsequently in case of any kind of side effects or any kind of issues which take place. Coming back to today's topic, which we all know that poisoning is a significant global public health problem. And I'll share with you I was in All India Institute of Medical Sciences those days from the armed forces, doing my postdoctoral fellowship in epidemiology. And one day I was called in the office of DGFMS, that is in Armed Forces Medical Services. And there were series of cases of the army soldiers going on vacation, transiting through Delhi. Suddenly they were found unconscious at railway station. They were brought to base hospital. They all recovered. So, but all their possessions and all were gone as such. So we investigated that Neela Thotha, which was that time copper sulfate as such. That was the substance which was used. So this I'm talking about 2000, year 2000, 25 years ago. We wrote a paper on that. We also talked about armed forces registry on poisoning and all. Since 1995 in AIMS, we have this, poisoning registry as such for the country. But then in 2004 or 5, we created for the armed forces also, where we link the data as such. So this problem of poisoning as such, this, that unintentional poisoning causes more than 1 lakh deaths and loss of 6.3 million years of healthy life, disability adjusted life years, because of this poisoning. And mostly these are in rural agriculture areas, low and middle income countries. And agriculture as it is, we know there are a lot of efforts also have been done by government, how to keep those in lock and key and how to have those committees and all, agriculture produce committees and all also to make them in charge of those. But then again, there is, so I will not say unintentional, they're sometimes intentional also. So, but then unintentional, of course, are more. And even it is linked to a large amount of mortality. And as per 2024 data of WHO, the mortality rate of unintentional poisoning in the world was 1.1 per lakh population, and same in India was 0.3. But then in India, poisoning 0.3 per lakh, we can't be feeling happy that it is much less than the world. because a lot of our data probably many times may be getting unreported also. And according to the National Crime Records Bureau, the latest reports of Ministry of Home Affairs, there were almost 26,000 cases of poisoning in 2021, out of which almost 1,800 plus were in children below 14 years of age. So that's a significant number. That's where the accidental intake and pesticides, insecticides, even labeling in our houses, and using old bottles and all for something else later on subsequently, that leads to unintentional poisoning. And the problem with is the diagnosis is that the community, it's even though the IEC and activities and all are ongoing in all parts of the country, but the symptoms of poisoning can mimic a lot of other symptoms, disease symptoms as such. It could be seizures, it could be looking like alcohol intoxication, it may be even stroke, or it can be severe hypoglycemic kind of reaction or hyperglycemic kind of reaction, and vomiting, diarrhea, drowsiness, confusion, altered mental state, skin, some kind of changes and all, difficulty in breathing. So all these can mimic various other diseases. So and the time is of essence of early diagnosis, early management, and that's why I think more knowledge about this among us healthcare personnel, and all subsequently as healthcare personnel, we must transmit this knowledge amongst the people also, and also the how to prevent and control this. And as I mentioned earlier, in the 1995 Department of Pharmacology, Organization of Medical Sciences, this National Poison Information Center (NPIC) was established, and this provides round-the-clock information on the management of poisoning to healthcare professionals, general public. Please utilize that also subsequently, all those who are joined online. So today there will be three talks basically: management of pesticides, poisoning in adults by Dr. Sumit Pachauri, who is a consultant, Department of General Medicine, MAMC, Maulana Azad Medical College, New Delhi. Management of poisoning in children by Dr. N. Jamshed, Additional Professor, Department of Emergency Medicine, AIIMS, New Delhi. And challenges, gaps and solutions for handling poisoning and emergencies by Dr. Sangeeta Sharma, President, DSPRUD. So I hope all those who have joined in this long weekend of Holi, and so again very creditable of all of you who have joined today. And so I hope the discussions will enhance the understanding, the strategies for detecting, early detection, early referral, early management, and now with the sub-center arm being strengthened, PHC Ayushman Arogya Mandir being strengthened, I think a lot of initial management of lavage, initial some drugs and all can always be instituted at these two, and that's where we need to strengthen our facilities further to look at all the accidents and emergencies, that one package of 1 out of the 12 which are there, to implement those 12 packages, our capacity building of our healthcare workers, and this is one of our efforts towards that. And I wish you all the very best, the large group of the specialists, the doctors, MBBS, the CHO, staff nurses, other professionals for other different disciplines. I'm sure a lot of pharmacists and all also will also be there. So I look forward to an interactive session. Please ask questions. Please, till you are satisfied with the answer. Even subsequently, you can always email questions to us. I'm sure the entire QPS team would be eagerly waiting to interact with you and discuss with you. And I thank on behalf of the NHSRC and DSPRUD to the experts, Dr. Sumit and Dr. Nair Jamshed, for taking their precious time out from their routine job, which is very, very demanding as such. So thank you very much for that, and looking forward to an interactive session. Thank you. All the best. Thank you.
Thank you so much, sir. Before I would invite Dr. Sumit, I would like to welcome Dr. Nair Jamshed, Additional Professor in the AIIMS, New Delhi, who has joined the webinar.
Thank you very much.
So for the first session, I would like to welcome Dr. Sumit Pachauri, who is an assistant professor and consultant in the Department of General Medicine and General Medicine at the Maulana Azad Medical College, New Delhi. His expertise is in managing complex cases of poisoning, especially the organophosphate poisonings, and the core competencies include managing medical emergencies and performing the emergency procedures. He's also presented and published various papers in the national as well as international journals and conferences, and also holds a fellowship in diabetes mellitus. Sir, over to you.
Good evening, everyone. I'm sharing my slides.
Aman, do you
Good
have
evening, everyone.
presentation with you?
Sir, if you are facing any difficulty, can we share your slides?
No, it's fine. Not responding.
Do you have your presentation open?
Yes, ma'am.
Then you can maybe you can select a screen or the presentation. Yeah. Yeah. Now you can open this one. You can open this. Yeah. Okay. This is the downloads folder, Dr. Sumit. Do you have
Yes,
this
ma'am.
saved on your computer? Perhaps that is why
Yes,
you're
ma'am.
not.
I have saved, ma'am. That is, ma'am. That is not actually opening, ma'am. I have downloaded also.
Sir,
I
I
don't know
can
why
share
it's
your
not
slides
opening.
if you want.
Maybe you go. I don't know. Because this is the downloads folder. It should open actually.
Sir, should I share the your presentation?
Okay. You can share. Sure.
Hmm.
Sir, I've shared the screen.
It's I can't hear him. I think he has logged out.
When he got logged out, he is joining again.
Okay. Dear friends, please bear with us. This small little technical glitch. Dr. Sumit Pachori got logged out. He's joining soon. Retest link. Okay, I'm sharing this again here in the chat box. A recording of this session will be available on YouTube channel of NHSRC, QPS channel. After a week or 10 days, you can find a YouTube recording of this session. In fact, you can find all previous session recordings on the YouTube channel of NHSRC. There is a QR code in the flyer. You can scan that and you can reach the YouTube channel. Maybe Aman, at the end, you can circulate that again.
Yes, ma'am.
Those of you who have joined us for the first time may not know. In the flyer itself, there is a QR code. So if you have received that, you can scan that and you will, it will take you to the YouTube. Recording, you can do it, and it's up to you. Is he having any problem joining? Aman, I think he's talking already. Dr. Jamshed का भी he is there. If he is having Aman, welcome, Dr. Jamshed.
Thank you, ma'am.
How are you?
I'm good. I'm good. How are you, ma'am?
Good, all good. Thank
If
you
he
for
is
coming
facing
in.
any problem, ma'am, can I start?
I think he has joined back.
Please join back.
He is
Okay,
logged in. Yeah.
Okay, ma'am.
Dr. Sumit?
Sir, you can unmute yourself now, sir.
Dr. Sumit?
Hello.
Yeah,
Yes,
yeah,
sir,
we can hear you now.
Sir, we can hear you. You can start. I will control your presentation, sir.
Okay. So now we are going to discuss the management of pesticide in pesticide poisoning in a patient, adult patient, adult patients. Change the slides. So first, the patient present with the poisoning. So either patient is suspicious with the poisoning or with the typical symptoms of the poisoning. So initially we assess the patient and we will do the ABC as the standard guide according to the standard guideline. That is we will assess and maintain the airway, breathing and circulations. Then we will collect the available evidence about the consumption of the substance, quality, order. It is very important. We have to take on the basis of this, we can get the exact idea about the poison in its form, whether it was a bitter, its form, whether it was a volatile, non-volatile, or gaseous, or it order, like it was a like a bitter order, or like a a fishy order, or kerosene like order, because sometimes kerosene like order indicate op like poisonings, and fishy order indicates towards like a paraquat like poisoning, and after that perform the detailed exam, quick and examination of the patient to get a further clue of the taxidrome, and send the lab test for the patients. Change the slide. So so there's a so if we found the specific toxins or compound, so treat accordingly. So immediate start the treatment, do a ABC. that is airway breathing circulations, then decontaminate the patient, give the specific antidote, and the elimination that we will further discuss in the next slides. If we are unable to found, then continue to the search, but do not forget that initial management, do a gastric lavage. We can, although we should do a gastric lavage as early as possible within a 1 hour, but we can do up to a 6 hour. And we should also do ingestion of activated charcoal along with the symptomatic management. Change the slide. Now the decontaminations, how we will do. So if the patient have a eye exposure, so then take a 50 ml syringe filled with the water. No, you can take any type of water, normal water or saline water, and ingest in the patient's eye, and thoroughly wash up to the 10 to 15 minutes. So we can able to wash out the toxins. If the patient skin is exposed with the toxins, then we should thoroughly wash the patient whole the skin uh, with the soap and or water, including the genital area, and remove all the clothes. Change the slide. The next thing is the gastric lavage. So what are the indications of doing the gastric lavage? So it is in a life-threatening poisoning and unconscious patient should do a within 1 hour with precaution to prevent the aspiration, because the risk of aspiration is very high in unconscious comatose patients. So in these patients, we have to maintain the airway first and secure airway first, then we should do aspiration. For a pesticide poisoning, uh, gastric lavage is useful up to a 6 hour, and we can extend after a 6 hour in few conditions. Tablet poisoning with anticholinergic effect presentation within 4 hours, and some sustained release preparations, salicylates poisoning, heavy metals, we can do up to a 12 hours. And gastric lavage we can do also do in iron and lithium poisoning. Please change the slide. So contraindication, as we all know, in a corrosive poisoning, it is highly contraindicative as there is a chance of perforation is very high. So we should never do a gastric lavage. And patient with the comatose conditions, or if we want to do patient came early, so we should secure airway as we previously discussed. Please change the slide. So where patient present, we should have in mind the taxidrome identification. So we get some idea that what we can suspect that what poisoning is going towards, whether it's going towards cholinergic poisoning and or opioid poisoning or aluminum phosphide poisoning. So we should remember some basic signs and symptoms. So like in OP poisoning and carbamate poisoning, we should remember that that in a patient of OP poisoning, there is an increased secretions of body. Like patient may have a increased urination and bronchoria, and uh, sweating, profuse sweating, and patient may have a diarrhea, vomiting. There may be a meiosis, fasciculations, bradycardia, and patient may found with the hypotension and decreased sensorium. And in patient with aluminum phosphide, patient maybe have a GI symptoms along with the typical fishy smell in breath and vomitus. And in parathyroid poisoning, patient presented with the blurred vision, with paresthesia, and with others involvement of others organs. Please change the slide. So the elimination is also a part where we remove the toxins from the body. So alkaline diuresis, it is a earliest and easiest method we are doing from the very long times. So it is most commonly and widely used and very easy method that we can easily done in even in a PHCs where we have no dialysis machine or no cartridge. So we just give a simple fluids along with some bicarbonate and potassium, so along with plus minus some diuretics. So this is a alkaline diuresis. So this is we just to give in uh, uh, some light acids. So they are salicylates and phenobarbitones and some methotrexate toxicity. And for hemodialysis, we choose those substances which are low molecular weight substance or which are water solubles like methanol, ethanol, glycol, salicylate, phenobarbitone, and carbamazepine, theophylline. These are the substance of choice for hemodialysis. And another is a method of elimination is a charcoal hemoperfusion. Here we have a cartridge of charcoal where is a plasma is moved through the charcoal cartridge where the charcoal is absorb the toxins. So this is quite used in carbamazepine and theophylline therapy, and also in a paraquat poisoning if patient came early within 1 to 3 hours. Please change the slide. So pesticide poisoning is classified into it can be an insecticide, herbicide, fungicide, rodenticides, or fumigants. Please change the slide. So the most common poisoning we seen in day-to-day in emergency is organophosphate poisoning. So although organophosphate poisoning have many manifestations, neurological manifestation, hematological manifestation, cardiovascular, but one of the most important manifestation we see is a neurological manifestations, and it is categorized into the type 1, 2, 3. So in early phase, that is, it is presented as a acute paralysis, and type 2 is an intermediate syndrome, and type 3 is organophosphate induced delayed neuropathy that we will discuss in detail later. Please change the slide. So if the patient presented with organophosphate poisoning, what we will have to do, how we will manage. So we will follow the simple formula as we do. We will follow a ABCD as we will discuss in previous slide, and maintain the patient vitals. We will look for the cholinergic symptoms and sign as we discussed, and we will do a decontamination, that is skin and gastric decontamination, and start the antidote if indicated. And we will do we will focus on a timely interventions. That is very essential, otherwise we will lose the patient. So if still we have a doubt on our diagnosis, so we can get a toxicology consultation, and there's some tests we can make a diagnosis, or we get confirm the diagnosis on the following tests. But we don't but in emergency we don't get time to do these tests. But one of the tests we generally have a clinical diagnosis, or one test we can do a bedside is atropine challenge test. So we can see the cholinergic crisis, that is a bedside clinical, and we can do a test is a we can withdraw the plasma of patient and send for the cholinesterase levels. So low cholinesterase level value suggestive of the OP poisoning, and we can identify the compound from the bottle label, that is we can get from the attendant, and atropine challenge test. And for that atropine challenge test, for the adult patients, we inject 1 mg of atropine to the patient, and see for the anticholinergic, and within a minute we look for the anticholinergic side effect. If there is a absence of anticholinergic effect, then there is a chance, then it is indicate that patient is then patient is poisoned with the OP or carbamate poison. So we can do this atropine challenge test, and dose is vary in children, but for the adult it is a 1 mg standard dose. Please change the slide. If the patient, so the scenario is that if patient present in a primary health center, what we can do when we take a decision to refer, and where we should refer a patient, how we categorize the patient, which category patient we should treat in PHC, CHC, and which facility we should refer. So if the patient present in a primary health center, we should do a ABC as we doing, decontaminate the patient and give a atropine dose. That we will discuss later, then how we will give the atropine. So after giving the atropine, then we will take the decision whether we have to treat the patient at the PHC or refer. So for this we have to do a para-DNA scoring system. So para-DNA scoring system, it is a OP poisoning it is a severity scoring system. So on the basis of this severity scoring system, we categorize the patient into OP poisoning into mild, moderate, and severe. So it is based on the patient's heart rate and heart rate, consciousness, and fasciculations, and other parameters. So basically they are zero. So basically on patient with a mild in a mild category, we manage patient to the lower center, or those patient who came into category that is score more than 4, we refer them patient, or patient came in category of moderate to severe, we then refer them to the higher center, that is tertiary center, or patient with having impending respiratory failure. Patient having a sign symptoms of impending respiratory failure, we refer them to the tertiary hospital where ICU facility is present. Please change the slide. So so the patient came to the emergency. We will do a gastric lavage and give activated charcoal to the patient. So there's a little benefit after 1 hour, and no benefit of gastric lavage after the 6 hour, especially in OP poisoning, as we already discussed. So dose of activated charcoal is usually we give a 50 gram dose to the almost all adult patient. The dose is 1 gram per kg within 1 hour, and should be repeated every 6 hourly for 24 hours until it appears in the stool. Please change the slide. So the main antidote is a atropine. So it has a standard dose, that is 2 to 5 mg IV bolus initial dose. So initially we give a 2 to 5 mg IV bolus and look for the patient atropinization. So so how we will assess the atropinizations? So we look for the 4 parameters, that is, if systolic BP more than 90 mm of Hg, heart rate is more than 90 per minute, chest is clear, there is no V's, no more V's, axilla is dry. So these are the parameters which suggestive of atropinization. So so if these parameters are not met, so we increase the dose every 3 to 5 minutes. We almost double the dose. Suppose if we give the 2 mg dose, patient is not atropinized, so we next time we will give a 4 mg dose until the V's and bronchial secretion is stopped. And one thing is more, tachycardia and mydriasis are not a good marker of atropinization. We should not, just by seeing the tachycardia or mydriasis, we should not monitor the atropine dose because they are not good reliable markers. Because the reason behind this, because they continue to be same in the condition of hypovolemia and hypoxemia and sympathetic stimulation. So they are less reliable. So that's why we not very sure on the basis of tachycardia and mydriasis. So, and in some clinical trials where it's found that if the maximum dose or high dose of atropine is failed to uh, improve the patient with the OP poisoning, it is found that the epinephrine was found to improve the heart rate and hypertension of patient, but not the mortality. But the heart rate and hypertension was seen to be improved. So if the patient was not able to maintain the heart rate or hypertension, then we can switch to the patient on the epinephrine therapy. Please change the slide. And one more thing on about atropine therapy. If during the atropine therapy, now up to now we have to decide up to how long we have to give atropine therapy. So once the patient is atropinized, so we should calculate the total amount of atropine, and we have to take a 10 to 20% of we have to calculate 10 to 20% of total atropine dose and give at rate of that 10% dose per hour up to 48 hours. Then after we should taper over 3 to 4 days in a severe cases of OP poisoning. And another thing is, if we found during the infusion patient having symptoms of OP poison, patient having a toxicity of atropine, then stop the atropine and wait till the atropine toxicity is stopped. That sometime on an average take 1 to 2 hours sometime. So stop for that duration and then restart again the atropine with lower dose. That is last time you have 80% of last time you have started the dose, and then restart the atropine with strict monitoring. And it was only about atropine. Now the pralidoxins. So this is the Another, apart from the atropine, this is the another therapy of auxins. So the role is still very unclear. So the benefit is found in severe OP poisoning cases, which is present early, and especially in patient with the diethyl OP compound only, because diethyl aging occur slower than the dimethyl one. So palidoxim have a role only in a diethyl OP poisoning, not in dimethyl. And there is a no role in carbamate poisoning. So it has a role only in OP poisoning. Systemic review suggests that palidoxim was associated with either null effect or harm. Side effects of palidoxim is laryngospasm, can cause tachycardia, allergic reactions, and rigidity in all body. And the dose, we give a stat dose of 2 gram in adult male, followed by the 8 mg per kg per hour infusion over a 48 hours, or after 48 hours, after a 24 to 48 hours till the atropine infusion stop. Please change the slide. Thank you. Now the benzodiazepine of benzodiazepines. So if the patient of OP poisoning presented with the seizures, we should not give the patient with the phenytoin, valproate. We should not jump. We should give a diazepam to the patient. And if the patient presented with repeated diazepam, we should go to the maximum dose of diazepam to the patient. Or we can start with the still patient have a seizure, then we can switch to the infusion of benzodiazepine. We can start or we can start a midazolam infusion, but we should not start a antipeptic drug, rather it causes a side effect. Please change the slide. So the prognosis, so death is usually occur 24 hours, within 24 hours if untreated, and within 10 days if treatment is failed. Recovery occur in 10 days, but there is some residual sequelae occur. So the discharging criteria: patient who recovered from the OP poisoning. So patient should be vitally stable and having a good respiratory efforts, having at least 20 SBP of more than 25, that is single breath count, and having good neck muscles activity, good neck muscle holding, and we should and psychiatric counseling should be done before the discharge. Slide. So this is a manifestation of, again, OP poisoning intermediate syndrome, that is occur 24 to 96 hours of post ingestion of OP poisoning. Usually seen in exposure to highly fat soluble agent, inadequate oxygen doses. Mechanism, it is a multifactorial, seen in a usually due to down regulation or desensitization of postsynaptical acetylcholine receptor, prolonged acetylcholine esterase inhibition, failure of postsynaptic acetylcholine release, oxidative stress related myopathy. Please change the slide. So it has a rapid progression which start from the ocular muscle first, then goes to the neck muscle, then proximal muscle of hands and leg, then respiratory muscle, and lastly go to the motor cranial nerves. There is a decreased DTRs and hardly there is sensory involvement. Please change the slide. So there's no as such treatment for the IMS. Mainly it's a supportive, take week to 3 weeks for the recovery. Now please change the slide. So another manifestations is a organophosphate induced delayed polyneuropathy, which is occur 1 to 3 week post ingestion of OP organophosphate agent like chloropyrifos. It has a characteristically transient painful stocking glove paresthesia, characterized by the symmetrical flaccid weakness starting in a lower limb and ascending up to the upper limbs. Please change the slide. And there is no current treatment of this neuropathy, and till now we are giving symptomatic treatment like pregabalin, gabapentin, multivitamins, and sometime tramadol. No such treatment is there till now. Thank you. Thank you, everyone. Any questions?
There is a question. There are a few questions, I think. When pupils are constricted fully, is there any role of giving atropine?
Sorry, ma'am, I don't get.
There is a question in the chat box. Somebody is asking if the pupils are constricted fully, is there any role of giving atropine?
Ma'am, if patient chest is clear, other parameters is fine, and despite of this, if the pupil is constricted, then there is we will avoid this condition.
Atropine, that means atropine is not given.
Yeah, ma'am.
Okay. Then second
I
question
think,
is about.
I think atropine, doctor is absolutely correct that initial for acute cholinergic syndrome, the initial parameter, that is absence of bronchoria and maintenance of heart rate and blood pressure, is totally okay. And pupillary constriction can be because of multiple reasons. It can be because of some other poisoning. It can be some other medical conditions. So if the constriction of pupil is still there, we are still giving 10 to 15% of the total calculated dose every hourly for at least 48 hours if there is acute cholinergic syndrome is present. So we will continue with that atropine therapy, but not in the same dose and doubling the dose every 5 to 10 minutes.
Thank you, Dr. Jamshed. Then there is a question about when atropine is given in hundreds of ml continuously without its anticholinergic effect, so much so that the thousands of 1 ml capsule given as undiluted drip. I think the dose is unlimited here. You have to achieve atropinization. And there is a high individual variability, so you have to keep titrating, and sometimes I think 100 milligrams of atropine may be required. Am I correct?
Yes, ma'am.
The maintenance dose of atropine post atropinization.
Ma'am, post atropinization, it is ma'am, total is 10 to 20% of total dose. So that we will give on hourly, ma'am, per hour.
Okay. So the treatment is continued even when the patient is symptom free.
Yes, ma'am. Ma'am, in
For how long will you continue treatment if the symptoms patient is symptom free after atropinization?
ma'am, ma'am, in patient of severe OP poisoning, we will continue for the 48 hours with the same rate, that is 10%, 10 to 20% hourly. After that, we will taper that initially with 10%, then 20, 5, then 5%, then 3%. That we will taper, ma'am, and we will taper over a 3 to 4 days. After 3 to 4 days, when patient become almost all right, all parameters are normals, patient having a no symptom is all patient all parameters become a normal, then will we stop after the 4 days, 4 5 days.
Okay. For how long injection pralidoxime should be given?
Yes, ma'am, that should be given up after, ma'am, after stopping the atropine. We continue after 24 to 48 hours. So usually we give after a usually in a common practice we give a 24-hour after till the atropine infusion stop.
And there is a lot of debate regarding the use of pralidoxime in OP poisoning. Multiple systematic reviews and meta-analysis is there that if you use pralidoxime in those patients, there is increased risk of patient having going in on ventilatory support and maybe increased mortality. So
Yes.
for as of now, unless until patient is having nerve gas toxicity or some very high OP poisoning with LD50 on a very higher side, and again, if you have decided to give pralidoxime, you have to start very early so that it can be reactivated, enzymes can be reactivated.
But once the time has passed, the pralidoxime will have a limited role.
Absolutely, ma'am. It will cause more harm than good.
So if you take a decision, start early, otherwise it will cause more. Then about, I think Dr. Sumit has already talked, if there is, a tachycardia is not a contraindication for use of atropine. You should look for signs of atropinization, that is dryness, dry, membranes, skin. Dr. Sumit.
Yes, ma'am. No, ma'am, tachycardia is not a contraindication, ma'am.
Yeah, it is not a
Yes,
contraindication.
ma'am,
So
it's
you
absolute
should
not.
continue to atropinize the patient till the dryness is achieved
Yes, ma'am.
of the secretions. Okay. Thank you, Dr. Sumit, for sharing your experience on managing this pesticide poisoning. And now we will move to the next session by Dr. Nair Jamshed. He's additional professor emergency medicine at AIMS. And he's a university gold medalist in his undergraduate days, has over 17 years of experience in emergency toxicology, cardiology, and evidence-based medicines. He's been very active academically, has published papers widely in medicine, toxicology, infectious disease, respiratory, endocrine, and then ultrasound guided procedures and cardiac emergencies. His chapters in many standard postgraduate textbooks. Dr. You haven't written your contributor in the standard treatment guidelines published by DSPRUD. This poisoning section is dealt by Dr. Jamshed Nair. Over to you, Dr. Jamshed Nair. Dr. Nair, are you able to share your screen? I think, Aman, you stop sharing?
My screen has already been stopped. I can share his presentation as well if he's not able to.
Dr. Nair, are you able to share today? Why is there is a problem? Can't even hear him, no?
Not now, ma'am.
For this, while we are waiting for I think for the doses of atropine and pralidoxime, you need to refer to the standard treatment guidelines. We have DSPRUD has published a standard treatment guideline book where there is a chapter on poisoning. In emergencies section, that there is a chapter on poisoning, and where many different poisonings are dealt individually also. So you can refer to the doses of atropine and pralidoxime in the book. Maybe I can put the link here. This is available on Amazon. Maybe if you are interested, you can go through that, or you can call the Poison Information Center. You should have those ready. They can guide you. There are several poison information centers, which are three of them. One is in Ames, the another is in Naipur, and I think one more in some Ahmedabad, and then there are several regional poison information centers. So whichever is nearest to you, these poison centers are working round the clock, 24/7. So maybe you can call them, and you can call them for various purposes. For if you are not able to make the diagnosis, you can tell them the symptoms. They can guide you how to proceed with this. And Dr. Jamshed has particular experience in of this poison center.
Okay.
Is the
Can you
क्या
see my
problem
screen?
क्या?
Can you see my screen?
Not yet, sir.
No, sir.
Can you see my
अभी
screen?
आप दिख रहे हैं. Now we can see you.
Can you see my screen? I have shared my screen.
No, sir.
Not yet. Not yet. Not yet.
Should I share, sir? If it
Share.
Yeah,
Yeah,
now
we
it is
can see.
coming. It is coming.
Can see.
Yes, we can see.
Can you see the screen?
Yes, sir.
Yes,
Yes,
yes.
sir. Yes. You can move to this full slide mode.
Okay. So good evening to all of you. Today, I will be discussing about poisoning in children. It is one of the very common illness for which the patient will be coming to the emergency department. So why is it important to know about poisoning in children, how it is different from the adults one? It constitutes around 13% of all poisoning cases in the emergency department, according to a report given by the World Health Organization. Children less than 5 years are commonly affected, and it is because they have the tendency, their inquisitiveness, and they're trying to keep everything in their mouth, putting everything in the mouth. That is why from 1 to 5 years, poisoning is very common. According to American Association of Poison Control Center, 1.1 million poisoning cases per year happen in the USA, which is less than 6 years of age, with a mortality of 45,000. This is World Health Organization report that out of these 13% of all poisoning cases, 45,000 deaths happen annually. And this around 5 per 1 lakh, if you see that mortality ranges from less than 1% in advanced countries to sub-Saharan or Saharan countries or the African countries, it may reach up to 5 per 1 lakh cases. So poisoning in children is absolutely different from the adult one, mainly because most of the time it is non-intentional. It is accidental. 99% it is non-intentional. And because in adults, they take large amount of poison to produce some harm. Children are unaware about these things. So because their poisoning is non-intentional, so they take a small amount because it is not very tasty most of the time. So, and they feel something abnormal. That is why they always take very small amount. And every time, the chances that it will be from a single poison rather than like in adults, they mix multiple things, alcohol with cocaine and this and that. Here it is only one. If it is acid, it is acid. If it is propranolol, it is probably propranolol only. Because they take single type of xenobiotic, the amount of intake is very small, so mortality will also be 1 to 2% only compared to the adult one. But unfortunately, the cost of getting treatment is very high in USA. It is around $6,000 per hospital admission. And according to the one report, the world spends around 1.9 billion US dollar to treat poisoning in children. But most of the time it is non-intentional, but in some of the cases, there may be homicidal intent, there may be intentional poisoning. And in intentional poisoning in children, 20 to 30% mortality will be there. Sometimes it reaches up to 30%. And it will be associated with some physical abuse, signs of child abuse, and may be associated with trauma. Physical trauma has been reported in one of the study up to 36%. When to think about that this is non-intentional and it was given for causing some harm to the child, when the history is very inconsistent. Every time you take the history is very inconsistent. Child of less than 1 year, there's hardly any pincer grasp. He cannot open the bottle, something like that. So injection in less than 1 year is always intentional with a homicidal intent. History of previous poisoning, history of previous trauma. If there is a history of massive ingestion, or doctor is saying that I have not seen any child before that with such a sign and symptom, probably your patient is suffering from child abuse. And if there is associated history of sign and symptoms of multiple xenobiotic, multiple poisoning, then it is intentional. So you must know that when to suspect intentional poisoning in pediatric age group patients. Probably you have to report to the various agencies. Why poisoning is so common in pediatric age group? It's because of the reasons. You can see beautiful pictures here. There is a closet. There is where you have put some corrosive and toilet cleaners, and because of inquisitiveness, the child is opening it and trying to taste it. Again, they copy adults. So if the drugs are lying open, they will consider it as candies and they will take it. Again, you can see here multiple toilet cleaners and Harpic, everything is there. And they have the habit to put everything in mouth. So the chances of poisoning is very high in this age group of the patients. So what are the common poisoning in children? Mainly, it is household chemicals, medicine, pesticides, workplace products, and heavy metals. And type of poisoning in children is very much similar to that of adult poisoning, because whatever is easily available in home will be a source of poisoning. So, for example, in AIIMS New Delhi, the commonest poisoning which is coming nowadays is toilet cleaner. So similarly, toilet cleaner is also very common in pediatric age group of the patient. Second is medicines, various type of medicine. If the nannies are taking some medicine or the father is taking some medicine and they are taking medicine in front of the child, they have this thing that they wanted to copy. So they will copy, they may consider it as candies, and that is why they can produce some toxicity. Pesticide and insecticide, if is available within the reach of the child, they may suffer from pesticide poisoning. And one important thing that you have to remember as a clinician, that sometimes child is not the culprit. Sometimes the doctors can be a culprit. He is not reporting, he is not giving the adequate dosing. For example, if I am saying that give clonidine 0.1 milligram and you wrongly interpreted as 1 milligram, that can be a source of poisoning. So according to one published report from JAMA, 0.47 to 5.7% of all pediatric toxicity is because of dosing errors. So principle of toxicology and principle of management of these patients will, most of the time, they are the same as the adults one. You have to resuscitate the patient and try to stabilize the patient, reduce the chances of exposure, diagnose which type of poison the patient has consumed, try to reduce absorption. If it is not possible, try to increase the elimination for dialysis or something like that. Give supportive care to all the organ which is failing. And if antidotes are available against that poison, give antidotes. So first and the foremost thing, like in any emergency cases, it is treat the thing which kills the patient first. So it is the airway, breathing, and circulation. Look whether the patient is breathing, is talking to you, whether there is any gurgling sound, airway is patent or not. If airway is not patent, just secure the airways. If patient is not breathing, give oxygen support, escalate the oxygen therapy. If patient is in hypotension, give fluids and vasopressors. So you have to maintain the ABC before doing anything. External decontamination before ABC is actually can be done in very few and selected cases, like chemical exposure. For example, there is an exposure of nerve agents and something like that. Then in that, when chemical exposure is there, then you have to decontaminate first before going for the ABC. So what are the important challenges that you have when you are securing airway? You can see here, there's a image of glottis. You can see that there is significant glottic edema because of the corrosive ingestion. So once you have decided that I have to secure the airway of this patient, intubation can be difficult. So you have to you have to prepare with the surgical airways also, because intubation can be very difficult and sometimes it can be very challenging. And it may be associated with some cervical spine, some trauma. So if you're manipulating the neck, there are increased chances that you can increase the nerve injuries also, neck injury, cervical spine injury also. So the most experienced person should intubate this type of patients. How to maintain the airway? There are multiple methods, like rapid sequence intubation is the best process, the best method we follow in our emergency department, where you actually pre-oxygenate the patient and then give induction agent and neuromuscular paralyzing agent. But some subset of the patient, for example, some sympathomimetic toxicity is there and patient is very agitated. There is no way you can pre-oxygenate the patient, and without pre-oxygenation, if you go to intubate the patient, there are more chances that patient will develop cardiac arrest. So you have to give something to sedate the patient. For example, you give ketamine, sedate the patient, and then pre-oxygenate, and then you can give induction agent and neuromuscular paralyzing agent for intubation. This is called delayed sequence intubation. Sometimes if you are not very sure, you can do awake intubation without giving any neuromuscular paralyzing agent. There is a concept of apneic oxygenation. When you have given neuromuscular paralyzing agent, there is cessation of the spontaneous respiration. You give high doses of oxygen therapy by nasal cannula up to 15 liters so that it produces some oxygenation to the lung. But apneic oxygenation is a matter of debate whether it helps the patient or not. And if everything fails, then you have surgical airways. You can go with needle or surgical cricothyroidotomy. Now about breathing. There are certain poison which will cause hyperventilation. For example, opioids. There may be some sedative hypnotic drugs. Aspiration of hydrocarbon will lead to aspiration pneumonitis and ARDS. ARDS can also happen in OP poisoning and opioids. And salicylate will lead to metabolic acidosis and patient will need respiratory support. So how will you give breathing? How will you give breathing support to the patient? you start with oxygen therapy, you escalate the oxygen therapy, like from nasal cannula to face mask and then non-rebreather face mask. If it fails, then you can go for high flow nasal cannula. If patient needs some positive pressure, you can use BiPAP or PAP, CPAP, continuous positive air pressure. If everything fails, then you intubate the patient and put the patient on mechanical ventilation. And when you have already intubated and put the patient on mechanical ventilation, lung protective strategy should be the way forward, where you start with 6 to 8 mL per kg and with a high PEEP. And you must remember that most of the patient can be in metabolic acidosis, where the respiratory rate is on the higher side just prior to your intubation. So your initial ventilatory setting should be matching with the intrinsic minute ventilation of the patient. So if your patient is having tachypnea initially, then you should keep the respiratory rate slightly on the higher side for initial few minutes. If your patient is having some problem in circulation, like patient is hypotensive, give fluids. And the initial fluid should be 20 to 30 mL per kg. If your patient is still not responding to your fluid replacement therapy, then put the patient on vasopressor like noradrenaline or adrenaline, inotropes. Like if your patient is having blood pressure on the lower side because of OP poisoning, atropine may help. If it is because of beta blocker, glucagon may help. Similarly, if it is because of calcium channel blocker, calcium may help. So you have to decide which therapy should be given to maintain the circulation. But initially, volume replacement and vasopressor should be started at the earliest possible. There are certain toxins which causes hypertension. For example, anticholinergic, sympathomimetic overdose like amphetamine, cocaine, something like that. So in that cases, initial treatment should be benzodiazepine. And despite giving benzodiazepine, if your patient's blood pressure is still on the higher side, give antihypertensive. Now, decontamination. How will you decon the patient? Once you are done with airway breathing and circulation, you actually focus on decontamination. So if your patient is still exposed to the chemicals or some poisonous substances, just remove the patient from that area, remove the clothing, wash with soap and water. If there is involvement of eye, irrigate the eyes properly for 15 to 20 minutes and other body cavities. Now, a lot of debate is going on whether to consider GI decontamination, like NG tube lavage should be done or not. In India, 50% of the poisoning cases are receiving NG lavage, but in Western world, it is just less than 1%. Once you are considering that probably I have to go for the GI decontamination, just remember 4 important questions. Is the ingestion potentially dangerous? If yes, you can go. Can emptying remove a significant amount? If yes, then you can do GI decontamination. Do benefit outweighs the risk? The risk is there is increased risk of aspiration pneumonia. There is risk of increased chances that patient will need ventilatory support later on. So if the benefit outweighs the risk, then you can go for decontamination, GI decontamination. And obviously, if there is no effective antidote, you try to remove as much as possible through GI decontamination. But American Association of Medical Toxicology, they suggest that it should be done within 1 hour of intake, unless until there is entry-coated tablets or delayed gastric emptying delay is there, where you can wait for 2 to 3 hours, where you can do it up to 2 to 3 hours. But initially, it should be done within an hour. After 1 hour, there's hardly any chance that it will be successful. So what are the cases where it should be avoided, where NG lavage should not be done? Ingestion of non-toxic agents or trivial ingestion is there, where the risk is more than the benefit. If there is a late presentation, by late presentation, I mean that a patient is presenting more than an hour of poison intake. If rapidly absorbed agents are there, for example, someone has taken large amount of alcohol and he is coming to you after 2 hours, there is hardly anything left to actually drain or clear out. If multiple vomiting is there, repeated vomiting, there is no need to do that. caustic and petroleum products, it is absolute contraindication. Either acids, alkali, or petroleum product, kerosene, never do. It will do more harm than good. So you have to go for the risk assessment. Take focused history, do meticulous physical head-to-toe examination, try to find that whether your patient fits into any toxidrome, send basic investigation, and try to find out if there is any antidote available against this poison. By focused history, try to gather most information. If there is a empty pill strips, empty bottles are there, some chemicals, empty chemicals bottles are there, try to find out what is the poison. If there is any previous medical record, patient already on beta blocker, patient was already suffering from antidepressant, from depression, and patient is already on antidepressant therapy, there are chances that patient has suffered from overdose toxicity of those things. So past medical records is very, very important. What is the timing of ingestion? When the patient has started the first symptom? Is any need for higher level of PPE? It is very important to understand that most of the time you don't need any high level of PPE in the emergency department. There's few studies which suggest that, for example, higher level of PPE is required in some chemicals, chemical toxicity, for example, nerve agent toxicity. You remember there was one sarin gas attack in Tokyo where the patient was flocked to the emergency department of Tokyo General Hospital. So some of the nursing officer developed toxicity by the OP poisoning. So in those conditions, probably you need high levels of PPE. Otherwise, what you normally use in your emergency department is sufficient enough to manage. And try to find out, was there any pre-hospital decontamination done to the patient or not? Again, check and recheck vitals, check the skin and mucous membrane, examine the CNS, any particular odors like kerosene odors is there, or having bitter element, or any specific odor is there or not. Any evidence of IV drug abuse, like needle tracks mark is there, multiple puncture sites are there or not, and whether your patient is having any stigmata of organ failure. For example, patient is jaundice, there is a rise in SGOT, SGPT, there is increased creatinine levels. So you have to find out any stigmata of organ failure as well. In CNS, we most of the time look for the GCS, what is the muscle tone, is there any clonus, opsoclonus, hyperparexia, what is the pupillary size, whether the pupillary size, pupillary constriction is there or not. So you have to remember all these things. Regarding toxidrome, it is nothing but constellation of signs and symptoms that consistently result from a particular toxin. For example, OP poisoning, there is meiosis, there is increased bronchoria, there is increased sweating, something like that. If all these signs and symptoms fits into it, then you can call it as a toxidrome of cholinergic poisoning. But unfortunately, most of the poisoning, they don't have a specific toxidrome. And if your patient has consumed multiple different types of poison, probably these toxidromes will not work. And sometimes they can have multiple overlap symptoms. So it was initially given by Moffenson and Grincher in 1970s, and it's an old concept, but it's still, if you get the sign and symptom which fits into a particular type of toxidrome, then you can manage the patient very easily. And these are various types of toxidrome that you may encounter in the emergency department, that is cholinergic, anticholinergic, opioid, sympathomimetic, sedative hypnotic, serotonin syndrome. So what are the important investigation you have to send in adults or pediatric age group patient? And there's hardly any difference. And then the blood sugar, hypoglycemia, hyperglycemia, ECG, chest X-ray, liver function, kidney function, electrolytes, blood gases for metabolic acidosis, alkalosis, something like that. You know that there are multiple types of poison where high anion gap metabolic acidosis will be there. You know that there is increased osmolar gap in toxic alcohols. So that may help in identification of the poison. Urine toxicology screen, we are getting a lot of requests from various departments that you have to do urine toxicology screen. We are suspecting, but unfortunately, it is not very helpful because of the multiple false positive and false negative results. If you really want to do something, you can go for the quantitative assay, that is gas chromatography, mass spectrometry, or liquid chromatography, or mass spectrometry. So it is very specific. The only problem with these techniques are that the turnaround time is slightly higher. So again, how will you treat any pediatric poisoning? It's airway, breathing, and circulation. If antidote is available, give antidotes. If patient is having hypothermia, give passive warming, do passive warming. If your patient is suffering from hyperthermia, then in that condition, rapid cooling will be helpful. And despite the fact that doing all these things, you have any problem, you can consult any toxicologist, any poison control center, any names. National Poison Information Center is there, and I have shared the number. You can note down the number. If you have any problem, you can ask the National Poison Information Center at AIIMS New Delhi. So these are the common antidote which is available for various type of poisoning. You all know that, like tricyclic antidepressants, sodium bicarbonate. Similarly, if your cholinesterase inhibitors, atropine is the antidote of choice. So I'm not going to actually read all these things. So my presentation will be with you. You can look at it later on. So if your patient is still suffering from poisoning and your antidote and your supportive therapy is not working, then there are other options where if you can increase the excretion of those poison, and various modalities are there. There is an extreme group that is called extracorporeal removal of poison. So according to that, your patient should fit into a particular type of thing. For example, if you want to do hemodialysis, intermittent hemodialysis, or continuous renal replacement therapy, the poison should be low protein bounded. It should have a molecular weight which is less than 500 to 5,000 Dalton. It's a small volume of distribution, and it should be water soluble. If the molecular weight is very high or small, volume of distribution is very, very large, it is highly protein or lipid bound, then you can go for charcoal hemoperfusion or plasmapheresis. But remember one thing, you only go for extracorporeal removal when their intrinsic removal by your own kidney is not able to clear the poison. And second, because the poisoning, there is a renal dysfunction. So in those two conditions, it is better for extracorporeal removal. So how poisoning should be prevented? Prevention is always better than cure. So according to World Health Organization, you should keep it up and away in lock and key. So it should be away from the reach of a child. Your important poison or important drug should be away from the child and should be locked and key so that your child should not reach it. It should be, there is a Packaging Act 1970, anything which is poisonous where it is more than 2% in concentration should be packed in a child-resistant pack. Don't take medicine in front of children because they have this habit of imitation, so they will imitate your drug intake. Every poison and every drug should be labeled with a warning sign. There should be a dose modification for safety. Just for example sake, it is better to have paracetamol tablet 500 milligram rather than 1 gram, so that a single tablet will not do more harm than a single tablet of 1 grams. Similarly, iron tablets like ferrous fumarate, if it is more than 60 milligram, it can be very dangerous to the children. So it should be in a small doses. So dose modification will provide a lot of safety to the children. You may use safe alternative. For example, there is a rat kill where you use either thallium or you use either aluminum zinc phosphide. If you remove it with warfarin or superwarfarin, it is more safe alternative than the zinc phosphide. Don't keep it with edibles. We have a habit that we mix sometimes some poison with the edible products. So there are chances that it may be mixed and it can cause significant amount of toxicity to even adults also. And keep the poison or anything in the original container. For example, if you see in the market, your toilet cleaner is available in normal drinking water bottles. So there are chances that your kid can take it, can consider it as a water. Sometimes we keep it some poison, some pesticide in Coca-Cola bottle, something like that. So in that condition, he may take it considering that is nothing but water or Coca-Cola. So now I will be discussing something which is very, very specific to pediatric age group. For example, caustic injection or the corrosive injection. Corrosive injection in pediatric age group is less in amount, so that is why this is less in complication. More associated with the splash injury, the chances that some burning sensation happen and the child will actually throw. So there are more chances of a splash injury rather than the actual injury. Complications like stricture can be seen in only 4% of the cases, where when you compare it with adults, where it is more than 20 to 30%. So 39% of the admitted, according to Hoffman, 39% of the patient who are admitted because of caustic injection, only 8% of the patient requires some treatment. It is just opposite to the adult one, where 46% of the patient got admitted, all of them, almost 88% needed some treatment. So this is very important for pediatrician, that any patient with caustic injection coming with stridor, there is no question, do endoscopy, upper GI endoscopy. Any patient who is coming with drooling and vomiting, do endoscopy. If the patient is coming with only drooling or only vomiting, you can observe this patient overnight. If your patient doesn't develop any symptom and patient is overly accepting, then you can safely discharge without any endoscopy. Now, button batteries injection is very common in pediatric age group patient. Button batteries are commonly used in various toys. So it produces injuries by 3 different methods. One is the direct pressure necrosis. It is electrically active, so it can cause electrical injury. It can release the corrosive, so it can also cause corrosive injury. So multiple methods are there by which button batteries can cause severe injuries. It can cause metal toxicity, mainly zinc, mainly lithium. So it can also produce some metal toxicity. And if the size of this button battery is more than 20 millimeter or 2 centimeter, it may cause impaction and obstruction. There are few methods are there where you may try, for example, giving honey 10 ml every 10 minutes for 6 doses, or sucralfate 1 gram every 10 minutes for 3 doses. But it may help you by actually removing the button batteries from the esophagus into the stomach. But sometimes it fails, and in that condition, you have to go for rapid removal of the button batteries at the earliest possible, preferably within 6 hours. Otherwise, there is increased risk of perforation. Kerosene and other hydrocarbons are very common in the rural areas. Fortunately, we don't see any cases in Delhi because it is banned. Kerosene is banned, but still it is available in the market. So how kerosene and other hydrocarbon causes toxicity in the pediatric age group? It is low. It is having a very low viscosity. It is highly volatile and low surface tension. So they have the tendency of producing aspiration pneumonitis, bronchospasm, and ARDS. So basic failure in kerosene and other hydrocarbon, why patient dies, is because of ARDS, development of ARDS. Apart from that, if there is ingestion, there may be some local complication like nausea, vomiting, abdominal pain. From headache to coma can be a CNS manifestation. But the main thing is that it causes severe aspiration pneumonitis and can lead to ARDS. So majority of the cases will be managed by your symptomatic treatment and the supportive therapy, put the patient on mechanical ventilation and give low tidal volume, high PEEP. So is there any role of steroids and antibiotic? Various studies are there which suggest that steroids may be given in selected cases and antibiotics may be given in those patients where there is some evidence of infection. Otherwise, routine use of steroid and routine use of antibiotic is not preferred. And this is very common camphor poisoning. You may be hearing about some of the sporadic cases of camphor toxicity. It is nothing but waxy, colorless solid with a strong aroma. You can actually smell it from a long, long distance. When you take it in mouth, it will produce burning sensation, oropharynx, and vomiting. But the major issue with camphor poisoning is that it produces neurotoxicity, and your child may develop multiple seizures. And because of multiple seizures, there may be some brain damage, and patient may aspirate and develop respiratory dysfunctions. Your patient may develop symptoms, sign and symptoms of camphor poisoning at 30 milligram per kg of dose. If it is 500 milligram per kg, 50% of the patient may die. So LD50 is 500 milligram per kg. And multiple balms are there, Vicks Vapora, Tiger Balm, but they use camphor at a very lower dose. For example, the Tiger Balm is 4.16% only. If it is more than 11%, then you cannot sell it in the market and you have to take all the precaution. It should be properly packed. So you have to give supportive therapy. You may try decontamination. The most important thing is that you have to give supportive therapy and control the seizures. If your patient develops some respiratory failure, put the patient on ventilators, and probably your patient may come out without any adverse outcome. Another important poisoning in which is very specific to the pediatric age group is the mothball or the naphthalene ball toxicity. It is an insecticide and pesticide which is commonly kept in the closet for keeping away from the insects to damage your clothing. And so it causes oxidative stress and direct mechanical damage to the RBC. And how the patient will manifest? Your patient will manifest with intravascular hemolysis. If there is intravascular hemolysis, it will lead to hemoglobinuria, acute kidney injury. And needless to say, again, there is no antidote available. You have to give supportive therapy if your patient develops some renal failure, which is the most important reason why the patient will be admitted to the ICU and a patient may die is acute kidney injury. You have to go for hemodialysis. Mothballs or naphthalene balls are highly toxic, so you may replace it with something which is less toxic. So we are now replacing it with 1,4-dichlorobenzene. It is a safer alternative to your naphthalene mothballs. Now, this is very common in the Western society and Western countries that detergent pots are washing powders, washing pot, detergent pot. It looks very bright and very attractive, and it is very attractive to the pediatric age group of the patient. It contains high concentration of ethoxylated alcohol, which acts as a surfactant, and it helps in the washing of clothes. It is high in alcohol and propylene glycol levels also. So it causes vomiting, salivation, increased salivation, and gastric burn. And sometimes it may lead to choking, coughing, increased coughing, and sometimes it may lead to seizures also. And death mainly happens because of the cardiorespiratory failure. But remember one thing, it is not that toxic, but your child may develop toxicity so much so that you have to admit the patient, and there are few case reports where the child died because of the detergent pot poisoning. Another common call that you will be receiving in your day-to-day practice that my child has taken something like Good Night and mosquito repellents, which is basically diethyltoluamide, picaridine, permethrin, alethrin. And there are two different types of poisoning you may look. The one is the type 1 where direct contact may lead to some hypersensitivity reaction of the skin. Sometimes it can cause vesiculobullous type of eruption. And patient may develop hypersensitivity, which leads to anaphylaxis-like thing. But type 2 is something where there is more CNS symptoms and respiratory symptoms. So fortunately, DEET, picaridine, permethrin, alethrine, they hardly cause any mortality. But few case reports are there because of anaphylaxis and some of the respiratory problem, patient develop cardiorespiratory arrest. Now, a snake bite, I'm just emphasizing one thing, that if there is any snake bite, the amount of venom injected by the snake will remain the same irrespective of the child or the adults. For example, if there is a cobra bite, around 150 to 200 milligram will be injected. Similarly, Viperidae, 150 milligram will be injected, more medium dose. So you need the same amount of ACE-V, for example, like 10 vials, if you are giving 10 vials in adults, so you have to give the same amount of vials to counteract the toxicity in pediatric age group also. Drug toxicity is very common in pediatric age group patient. It is because you are leaving the drugs here and there, for example, mainly paracetamol and seed opioid, which is commonly available at every house, beta blocker, calcium channel blocker. Most of your parents and grannies are taking beta blocker, calcium channel blocker, some anti-diabetic drugs. The only difference between adult and the pediatric age group is the amount of dose which is required to produce significant toxicity in pediatric age group of the patient. So even paracetamol 2-3 tablet is significant, will cause significant paracetamol poisoning in pediatric age group patient, but it needs 6 to 10 grams at least for adult toxicity. Management wise is same. The way you manage drug toxicity in adult will remain the same in the pediatric age group also. So what is the take home message for all of us is the pediatric poisoning is common. 30% of all the patient in the emergency is because of poisoning in pediatric age group. Because of the inquisitive nature and their tendency to take everything in mouth, so it mostly affect 1 to 5 years of age. Mostly it is non-intentional, it is low dose, it is mostly single drug only, and that is why it is less associated with mortality and morbidity. But remember one thing, sometimes intentional poisoning can happen. So in that condition, you have to think about the child abuse as well. So thank you very much for this opportunity today. If you have any information, my contact information is here. You may mail us and you may ask any question on these sites also. Thank you.
Thank you, Dr. Jamshed, for you making it so easy. It's a big topic. I think in an hour, 45 minutes is very difficult to, but I think you've all got the, principles behind management, what is the poisoning, why it happens, how do you do, and the principles of treating poisoning in children. If there are any questions, you can write here in the chat box. Meanwhile, while they are writing,
I think we have
may I ask
3
you?
questions, ma'am.
Yeah, I think I answered 1 or 2 when they were there. Very often it is seen people induce vomiting. Can you, elaborate on this, whether it is needed?
There is very clear-cut guideline given by the American Association of Medical Toxicology and American Association Poison Control Center that it should not be induced. That is why there is hardly any role of EpiCac nowadays. There is no role of induced vomiting. It will increase the chances of aspiration and it is not helpful at all. So please don't do it.
Yeah, many people, try this at home. So there is a role of public education also on this, that this is not needed. There is another question. Is camphor burning or sublimation during pujas a potential poisoning risk?
No, not at all. It all depends on the concentration that you are exposed to. For example, tiger balm, Vicks Vaporub, which is applied on head and the chest area, the concentration is only 4.16%. So if your concentration somehow increases more than 11%, you have to remember one thing, that it should not be very closed space. and burning of camphor and during various pujas and rituals, it should be not in kilograms. So if it is in kilogram, then there will be a problem. If it is a closed space, then will be a problem. So just burning few grams of camphor will not do any harm. There is a very common saying in poisoning: just dilute the poison and you will be okay.
Yeah. Anything else on the pediatric? I think there were a few questions on the organophosphate poisoning. Can you just summarize the take-home messages on organophosphate? Particularly, there were questions about atropine dose. What is the maximum dose? For how long should you be giving? And whether can you give these in pregnancy?
Yes, ma'am. There are multiple trials are there where they try to see what should be the ideal dose and how it should be given. So we can start. There is one trial which try to see the efficacy of your atropine efficacy when you are giving fixed dose. For example, 2 grams every 5 to 10 minutes, and then 2 grams. If there is no atropinization, you increase double the dose every 5 to 10 minutes. So by doubling the dose every 5 to 10 minutes and by giving the fixed doses, they came to a conclusion that time to successful atropinization is very, very less. So you have to double the dose every 5 to 10 minutes till the features of atropinization is there, number one. Number two, there is less chances that your patient will die or less chances that your patient will require some ventilatory support when you doubling the dose every 5 to 10 minutes. So the doubling of the dose is the way forwards. Now coming to the how long we should give. So it all depends upon the cholinergic toxicity. If your cholinergic toxicity is very severe, so it is the same continuum. For example, if your cholinergic symptom is very severe, there are more chances that your patient may develop intermediate syndrome also. So it is better that once you have achieved the atropinization, then whatever the dose you have calculated for atropinization, 10 to 15% should be continued for at least 24 to 48 hours. And then you can taper it off depending on the condition of the patient. And but again, remember, you have to be on the bedside, you have to continuously monitor the patient.
There is a question. Atropine in infusion form, like 30 ampoules in 500 ml normal saline until atropinization. Is it safe?
No, no, no. The very clear cut criteria I have told you that there is no fixed doses. You start with 0.6 or 1.2 milligram and then double the dose every 5 to 10 minutes till you have achieved the atropinization. And this should be the way forward. What we are doing that we are short of the nursing officer. There are few nursing officer who is not standing on the bedside. The doctor is less in number. We have crowded emergency. Then this is the second other option, that just give it in a continuous infusion. But definitely you're doubling the dose till atropinization is achieved is the better option.
Can we give atropine and PAM together?
Yes, you should give both of them together. There is no doubt about it. If you have to give PAM, you can give together, because you have to start at the earliest possible. The more you delay the administration of PAM, less likely that your PAM will work. Now, remember one thing again. I have told you also that there are multiple trials are there, multiple meta-analysis is there, which suggests that PAM role in OP poisoning management is doubtful. Keep it for some rapidly acting like nerve agent, some OP poisoning which is highly toxic, where or class 1A and 1B of OP, where you can give very early to get the desired result. But overall, we don't use PAM in our emergency.
Okay. there is a question, at a CHO level, what should they do when they come across OP poisoning case?
I can understand that there is a OP death in OP is mainly because of respiratory failure, because of pulmonary edema and ARDS. And you start with the oxygen therapy, and as soon as you receive the patient, start atropine.
So CHOs can start atropine. Or, many times what people, common thing is that they start arranging for the referral. And
No, no,
that
no.
if there is a delay.
Even if you want to refer the patient, start giving atropine, and then en route also you give atropine till the patient reaches to a higher center. But atropine is the antidote of choice. It will save the life of the patient.
Then somebody is writing, good night, flash liquid accidental poisoning in children. Repeat the treatment protocol. How would they be treated?
Regarding all-out poisoning,
That good night poisoning, liquid
All
poisoning.
out liquid poisonings.
basically it consists of alethrin, pyrethrin, DEETs. So they are not very toxic. So there are two different types of toxicity reported in alethrin or cypermethrin type of poisoning or DEET poisoning. One is the local hypersensitivity. So if there is a ingestion, there are chances that patient may develop hypersensitivity, sometime anaphylaxis. So this will not cause death because of poisoning, because of hypersensitive reaction and because of the airway compromise.
So
Relatively safe, but you have to be careful about the ingestion. Sometimes they may present in few cases as hypersensitive reaction where you have to safeguard the airway of the patient.
I think the questions
Most of the time, there is no need to panic. It is very, very safe.
Okay, many times people also hesitate. Either they don't know the poison control center nearby or information center. What all things that they can get from these poison control center and information centers?
We have a
You know,
poison information center. We do not have a poison control center, ma'am. So you may get some of the basic information. For example, if your child has taken some, just put some all out in mouth and now he's okay, the poison information center may ask some of the basic question. For example, is there any salary? Is there, whether your child is talking to you? Do you think there is any gurgling sound? Is there any large swelling present or not? If nothing is there, don't come to the hospital. This is the role of poison information center. If these things are there, if there is salary is there, patient is not able to talk, there is significant amount of edema, then please come to the hospital.
But what if there are intermediate symptoms, later, sometimes it may not be obvious immediately, but after some time some symptoms may appear, or maybe chronic toxicity effects appear. So what do they do?
Most of the poison, they cause toxicity within 6 hours. So if you do not develop any sign and symptom of that particular toxin, probably it is safe to discharge the patient from the hospital. But some of the poisoning can have a delayed presentation. For example, someone consumed entry-coated tablets, sustained release tablets, or there is a body packers which may burst later on and produce toxicity. So in that condition, there is a need to observe the patient further.
So, what are the general guidelines? Suppose the child had symptoms, you admitted it, provided the first aid and the treatment. For how long, in general, guideline, for how long the patient should be kept in observation?
If your patient is asymptomatic, discharge the patient within after 6 hours of observation. If your patient is symptomatic, then you have to keep the patient in admitted in the hospital, and after the symptoms resolve, you can discharge the patient after 12 to 24 hours of symptom-free period.
Yeah, this is important. Many times in snake bite cases, the patient recovers, the patients are discharged, early. So at least they should be kept under observation for 24 hours. And Dr. Nair has already emphasized on the dose of anti-snake venom. It remains the same as in adults. And this is true for other, medications and the doses as well. Many of times we consider that the children are half adults. So we give half the medicines. The dosing errors, what Dr. Nair was mentioning, they happen because, many times we ourselves do not know what is the strength of the medicine in there. How much does this 5 ml contain? And this actually stems from a notion that all preparations which are available in the market are interchangeable. So, especially with iron preparations, you will find there is a wide variation in elemental iron. And many of us think that 1 milligram is equal to 1 milligram of elemental iron. So, and kitchen spoons are used, for dosing. So
Spoon.
all these things are reasons for dosing errors. So these are well within our domain that we can educate the parents about this, not to use kitchen spoons. If possible, use the measuring cup or the oral syringes for accurate dosing of these medicines to avoid poisoning in children. Although they are, Dr. Nair has mentioned that it is, because of the curiosity that the child takes, and usually it is a small amount, but in children, being, they are more susceptible to the toxic effect. So even 1 or 2 tablets may cause some symptoms in children. Am I right, Dr. Nair?
Yes,
On
absolutely,
this?
ma'am. Absolutely, ma'am. Most
And
of
the
the time they
symptoms
take
may
a small
progress
amount,
rapidly.
but that small
Yeah.
amount can be very toxic. For example, iron, agar elemental iron is more than 60 milligram, that can be a source of toxicity to the pediatric age group. 60 milligram of elemental iron will do nothing to an adult. Similarly, paracetamol, acetaminophen. Acetaminophen normally 15 milligram per kg, but in children, for example, 2-year child, if child has consumed 1 gram tablets, 2 tablets of 1 gram, that is significant toxicity. Nothing will happen in acute toxicity unless until an adult has consumed more than 10 grams. So this is the difference as far as the drug toxicity in pediatric age group patient is concerned. That even a small amount of thyroxine can be very, very dangerous.
Yeah, even 1 or 2 tablets of thyroxine.
100 to 150 microgram of thyroxine can be very toxic to the child.
And calcium is another, preparation which is kept at home, and very often children find it, and the taste is, they like chalk-like
Chocolates.
taste also, so they consume this calcium tablets. So even 2 tablets is, maybe toxic for the child. Any other question? I think regarding the challenges, gaps, and solutions, I think we have already discussed this. Children, because non-specific symptoms, Dr. Nair has already emphasized on this, and the pesticide poisoning. So the ultimate is that we should know, what to do. Keep the emergency numbers ready, and ask the patient or parents also to keep this ready. Maybe a refrigerator, they can have some, what is magnet like thing, so that these numbers are ready, so you don't waste any time. And never ever tell children that medicines are like candy. Many a times many a times in our endeavor to encourage them to, motivate them to take medicine, we tell them that this is like a candy, it's sweet, orange, strawberry, but don't ever tell them, because of their inquisitive nature, they may try, taking in your absence, and they may poison themselves. So keep them away, out of reach, Don't keep these medicines in your kitchen cabinets. Sometimes children are so inquisitive. They will keep stool रख के ऊपर चढ़ के refrigerator के ऊपर रहता है, वहां पर भी रख के चल जाते हैं. So you have to be careful. Prevention is the key. Regarding organophosphate poisoning, decontamination is very important. And one thing, when you are decontaminating the patient, take care that you yourself do not contaminate during this decontamination of the patient. So wear all the personal protective equipment when you are decontaminating, so that it does not, because absorption from the skin is very good, so you can be also getting this contamination while treating your patient. And dispose of all the gastric lavage clothing in a bag, proper bag, so that it does not contaminate others during the treatment process. Anything else would you like to say about gastric lavage? I think you've already said. That's it, I think. There are no more questions. We
The
can.
problem,
I think there
problem
is
with
one
us-
more question, ma'am. Somebody is asking if sir can brief on Jatropha poisoning.
Which poisoning?
Jatropha.
Which
Can you
Jatropha
lavage?
poisoning. Jetropha.
what is this?
Maybe what
Jatropha
about
seeds.
the
Poisoning from
arrhythmias?
Jatropha seeds.
Okay. What about the arrhythmias from the poison?
Ma'am, arrhythmia is basically we have seen so many cases of TCA poisoning where there is widening of the QRS because of they have a sodium channel blocking effects. So any drug like sodium channel blocking agent, they have the tendency to widen the QRS. If the QRS widening is beyond 160 millisecond, there are increased risks of sudden cardiac arrest because of ventricular fibrillation and ventricular tachycardia. So sodium channel blocking agents, beta blocker, calcium channel blocking agent, digoxin toxicity, they all cause various type of arrhythmias. And if your patient is developing these type of arrhythmias, you may treat it with lidocaine and sodium, for example, sodium channel blocking agents like TCA poisoning. Then bicarbonate should be given to all those patients. So this is the way we actually manage. Yeah, if you ask me specifically about some specific poison, I will be able to answer it.
These are
The
Jatropha is
problem
a
with
ratan.
the problem with amio and other antiarrhythmic drugs that amiodarone can increases the QTC. So your patient may develop polymorphic ventricular tachycardia. So be sure if you are using amio for treatment of poisoning, in that condition, QTC should be normal and there should not be a very wide QRS complexes. For all practical purposes, if there is a wide complex, give bicarbonate and then you may try lidocaine also.
Dose of paracetamol
Similarly
in
with seizure. Seizure is very common in poisoning. So normally in various cities and various small towns, they have the tendency to give phenytoin rather than benzodiazepine. So it is better to avoid phenytoin because phenytoin itself can cause toxicity. It is a sodium channel blocking agent. So it may lead to arrhythmia and seizure. It can produce seizure. So it is better to give benzodiazepine in toxin first, and then you can try levetiracetam. And if it is not responding to anything, then you may try these things. But try to avoid phenytoin.
regarding dose of paracetamol, it is 15 milligram per kg body weight in children.
Yes, ma'am.
In general, if you want to be sure about the dose, we all have smartphones now. Dose calculators are available on the internet. Maybe you can type the weight of the child, and it will give you it will give you how much ml of a particular strength that you are using will be also given. So try using that. It will be helpful in optimizing the dose in children. जेट्रोफा सीड्स सर वो है रतनदीप कुछ सीड्स हैं वो होता है and it is quite toxic.
Rati seeds.
Ratan Jot, this
Are
is
you
what.
talking about Rati seed, which is used by goldsmiths and where there is aberrant toxicity, chances of aberrant toxicity is high? Are you talking about that?
पता नहीं सर ये अभी मैं नेट पे ही देख रही थी सो आई हैवंट आल्सो हर्ड ऑफ दिस पर उसमें ये रतन जोत सीड द कॉमन नेम इज रतन जोत सीड आई डोंट नो फॉर व्हाट वी नीड टू रीड अबाउट दिस
One seed which is very toxic, that is Rati, which is Abrus precatorius, which is used by the goldsmiths, and that releases a toxin which is called abrin, and it is highly toxic. Even 1 to 2 seed is actually fatal, can cause fatal poisoning. It will lead to hemorrhagic gastritis and multiple hemorrhages from various sides. So if he is talking about Rati seed abrin toxicity, then basically hemorrhagic gastritis and hemorrhages is the commonest manifestation.
ये जेट्रोफा रतन जोत is a biofuel plant. I don't know how
I'm not
common.
aware of.
Yeah, we need to read about this, more about this. They are black in color. Yes, I did see this on the internet. Anyway, we can, Dr. Nair has shared his mobile number. You can always call on the Poison Information Center. They can give you more information on this. I think you will, next session is on acute and chronic otitis media and ear discharge on 19th of April. So we'll see you then for the next 5th session on acute and chronic otitis media. And with this, I will like to close. There are no more questions. Aman, we can close.
Yes, ma'am. First
Thank
of all,
you.
I would like to thank our esteemed speakers of the session, Dr. Sumit Pachauri and Dr. Jamshed Nair, and Dr. Sangeeta Sharma as well. I would also like to thank our advisors, sir, Dr. Jain Srivastava, sir, and our Executive Director, Major General Professor Atul Kotwal, sir, who have been very instrumental in these series. I would also like to thank all the participants who have been very patient in getting the knowledge from our esteemed speakers from the last, I would say, around 2.5 to 3 hours. And as told by Sangeeta ma'am, the next session will be on otitis media on 19th of April. That is again the third Saturday of the next month. Thank you so much, everyone.
Thank you.
And
Thank you, Dr.
also,
Sumit.
I would like to inform that the link to the post test and the feedback form and the YouTube channel of our QPS division, where you can find all the previous webinars and other informations as well, have been posted on the chat box, and I've again posted it. Please refer to those as well. Thank you so much.
Thank you, all of you.
Thank you.
I can leave, Aman?
Yes, ma'am.
Okay.
Thank you so much, ma'am.